Hello, everybody, and thank you for joining today. Today, we're going to be talking about some of the short stay quality measures, specifically those related to the SNF Quality Reporting Program, or QRP. We've been getting an increasing number of questions on this topic internally, so I imagine you all must have plenty of questions too. We'll talk about what the quality measures are, what they really assess, how they're calculated, and why they matter so much. My name is Haley Huckabee. I'm the Director of Clinical Excellence for TMC. I'm a speech therapist by background and also have my RAC-CT certification. I've worked for TMC for the last 12 years in a variety of different roles and found my home in clinical excellence for about the last 6. A little background on the SNF QRP evolution to set us up. It started in 2014 with the introduction of the IMPACT Act, which focused on quality outcomes. In 2016, Section GG was introduced and further expanded in 2018 to include outcome measures. Now, in 2020, these outcomes are publicly available, so this likely explains why there are an increasing number of questions coming up. So why is this important? First of all the information here is public-facing, as I mentioned, which means that anyone who is researching your facility has access to see this information. They will be able to make judgments on the quality of services you're providing based on what they see on Nursing Home Compare. Second of all, the SNF QRP directly impacts reimbursement through the Annual Payment Update, or APU. This is a percentage adjustment, either positive or negative, to the facility's annual payments from Medicare. So the big takeaway here is what we code on the MDS impacts reimbursement and therefore patient care. Digging a little deeper, remember that the goal of PDPM was to more directly align the resources given to a patient with the characteristics of that patient, hence the name patient-driven. Think of it this way. If we provide treatment to a patient that's not supported by the MDS, then essentially we are providing that service for free. On the flip side, we could end up documenting that a patient may have need for certain resources that we do not provide, and that's a serious issue. When our provision of care is not aligned with what's on the MDS, the questions arise. Are we providing services that are unnecessary? I hope that's not the case. Or are we not accurately capturing things that would support the patient's need for services? Both of these scenarios have serious implications. All right, back to the quality measures. The 4 newest measures that were added to the quality reporting program are calculated based on Section GG information at admission and at discharge. The first 2 measures are change in self-care and change in mobility. And these measures report the average level of improvement in each of these areas from admission to discharge as it compares with the expected level of improvement. The goal for these quality measures is to be higher than 0, which would correlate with an improvement from admission to discharge. In this case, higher is better. There is no national comparison for this quality measure. It simply reports the overall change and whether it's positive or negative. We'll work through an example in a minute that will make things more clear. The other 2 measures are discharge mobility and discharge self-care. These measures report what percentage of residents are at or above the expected level at discharge. The goal here is to be higher than the national average. And again, the higher the number, the better the overall resident outcomes are. Before we go to the examples, I want to talk about covariates and risk adjustment. It's not something we've really dug into a lot in the past because it can get confusing, but it does matter. Covariates are used to adjust the outcomes based on patient characteristics. We won't go through the individual covariates for these quality measures in detail, but I have listed them here for you. The ones in the first section of the chart apply to both mobility and self-care, and then the ones on the bottom half of the chart only apply to the area they're listed under. Again, all of this information comes from the MDS, so accurate coding is essential for reasons we'll discuss when we talk about the calculations. Okay, let's look at how the 2 change measures are calculated first. I want to note that these quality measures don't include every item in Section GG from self-care and every item in Section GG from mobility. There are several that are excluded, but most are included in the calculations. So these quality measures start by calculating the change from admission to discharge in the self-care and mobility areas. The changes are averaged by dividing the total change by the number of Part A residents, which gives you your facility observed change. This number is then compared to the expected change. Based on the characteristics of the patients, CMS predicts what the expected change score for each of these areas should be. So based on the diagnosis, admitting functional level of each patient, CMS will estimate or predict how much improvement they think a patient should make. One common misconception is that this number is based on what is entered for the discharge goal in column 2 of section GG, but that actually has no impact on this quality measure. The expected change is a theoretical number based on how patients with similar characteristics have compared in the past. This number is also averaged for all patients in the specified time frame to give an overall facility expected change score. The facility expected change score is then subtracted from the facility observed change score, and that is the number that's reported for this quality measure. I do want to mention one other misconception is that artificially coding a patient lower at admission will help show more improvement at the time of discharge. However, this can backfire as a lower admission score might create a higher expected discharge score because there's more room for improvement. So accurate coding is ideal, and trying to game the system won't pay off. Let's look at an example that will hopefully make it more clear. In this example, we have 3 patients in our observation period. In the second column, we have their observed change in mobility scores. This is how much improvement they made from admission to discharge as documented on their MDS assessments. In the third column, you'll see what their expected change in mobility score was. Again, to reiterate, this is based on CMS algorithms that they created based on their historical data. Those numbers are each averaged, and then the expected change score is subtracted from the actual observed score. So you can see in this example, the difference is 0.4. Since that number is positive, that means that on average, patients at this facility performed higher than the expectation, so that's good. The higher this number is, the better the patients are performing. If this number were to be negative, it means that the patients are showing less improvement than what would be expected. Now let's look at the discharge measures and work through an example. So for these measures, the GG scores in each of the areas are summed up for each resident, which gives the resident's observed score. Again, CMS calculates an expected discharge score based on those patient characteristics. And again, the expected score is subtracted from the actual score. This is divided by the total residents discharged in that time frame. The calculation up to this point is very similar to the change measures, but then there's an additional step. So let's look at the example as a way to see this. In this example, we have 4 patients being used in the calculations for this time frame. In the second column, you'll see their observed discharge self-care scores. So this is the sum of all those self-care items that are included in the measure. In the third column, you will see the expected discharge self-care score. And then in the fourth column, I've noted whether their observed score was higher than the expected discharge score or lower than the expected discharge score. The way this quality measure is reported is what percentage of patients were higher than expected at discharge. So in this example, 2 of the 4 were higher than expected. So the quality measure would be reported as 50%. This says that 50% of the residents in this facility performed better than expected at discharge. Obviously, the higher the number, the better, but this measure is reported against the national average, so a good initial goal would be to be higher than that national average. Now, I know I've been talking about how accurate MDS coding is vital for a lot of reasons, but I do hope you're starting to get a better picture of why the GG assessment is not just another to-do list item. It really does impact so many areas that are important to our facilities, and in some cases directly impact reimbursement. Section GG should not be something that we hurriedly complete and then forget about. It should continue to influence the goals of our treatment, our plans of care, and our interdisciplinary teams. It should be an accurate reflection of what's happening with our patients. Now, what happens when the quality measures don't seem to match up with what's really happening in your facility? Let's talk through a simple approach we can use as leaders to ensure better outcomes and that our documentation reflects the outcomes that we're actually achieving. We want to start with training. Do your team members understand the measures? Okay, now do they really understand the measures? Do they understand how they're calculated, who is included and excluded in each one, and what the covariates are and how they can impact scoring? This is important knowledge for both therapy and nursing to have. Once we've completed the training, then we want to do an analysis. We want to figure out what are the things that we can control. So first, do you know your scores? Once you know the score, do you know the context? Is it good? Is it bad? Is there room for improvement? And what might be influencing your scores? Are there coding issues, clinical issues, or both? The results of the analysis will guide the type of education we need to do and will be dependent on what issues we identify. If you think there are clinical issues, then here are some things to consider. How are we collecting this information? Are we all speaking the same language? Does nursing understand what therapy means when they say contact guard? Does therapy understand what extensive assistance means when nursing documents it? Is our treatment effective and in line with evidence-based practices? Are we assessing the correct component skills for each item? For example, in section G, bathing includes transfers in and out of the tub, but in section GG, those transfers are excluded when scoring. Another point of confusion is, are we supposed to document usual performance, as in section GG, or most dependent performance, as in section G? It's important that everyone understands the subtleties of scoring. Then, if we think it's a coding issue, we need to verify and make sure our coding is complete, that it's accurate, and that it is collaborative. And once we've provided the appropriate education, we want to monitor the outcomes. We want to make sure our education sticks, in other words. The best approach here would be to monitor your CASPER report at 30, 60, and 90 days. Are you seeing changes? Are they positive or negative? This can help you decide whether you need to provide additional or different education, or whether you simply need to better create accountability to the education you have provided. So here is an example of how that process was applied in one building. For the education piece, an in-service was provided for all nursing, CNA, and PT and OT staff on collecting self-care information for GG. They reviewed what subcomponents and skills were included in each item, which ones were excluded so that they could be documenting more accurately and consistently. The MDS coordinator and the DON's analysis showed that staff was frequently underscoring bathing ability when patients had difficulty with transfers in and out of the tub. Now remember that for bathing, transfers are not part of the scoring for bathing in section GG. Following the training, reminders were posted on documentation portals on how to assess bathing ability. At the 30-day mark, admission scores for bathing were more consistent and staff was able to verbalize their process of assessment. This resulted in a slight improvement in bathing ability overall, which led to adjustments in expected discharge scores that impacted both the change and discharge quality measures. This is the application of the process in one specific area. Your education and monitoring will be dependent on the specific issues you identify in your analysis. Sometimes simple changes will make a big impact, and sometimes it might need to get more nitty-gritty. So in summary, first we need to understand the measures and know what we are actually measuring and assessing. Then we need to make sure our quality measures tell the story of what's actually happening in our building by training, analyzing, educating, and monitoring. Here are some resources that may be useful in your training. We've been asked about providing supportive documentation for section GG, and that is a great question because we are seeing an increase in denials based on section GG when there is lack of supportive nursing documentation for the levels documented. So you definitely want to make sure that you're not just taking therapy's word for what section GG is or using one source of information. Like I said, this is supposed to be usual performance, so you want to collect that information over a variety of shifts from a variety of different staff members, different times of day, to get as much information as possible and making sure that information is included in the medical record. Another question is where to start collecting the information related to these quality measures. So right this second, you can go into Nursing Home Compare and pull up the information by searching for your facility name. Now this is the public side of it, so it is reported in its most basic form, but if you need more in-depth information, you'll want to use your CASPER system. So in the CASPER reporting, you'll find detailed information about your numerator, who's in your numerator, the denominators, and more information on the expected CMS levels. All right, I got another question about eliminating section GG. Yes, technically section GG has been removed from the MDS. although it is still available primarily because some states still use it for their Medicaid payments. And then also it still plays into these quality measures. I expect that CMS will be announcing changes to how these quality measures are calculated based on that, but we haven't heard anything yet. One last question is clarification on the scoring of that discharge quality measure. Remember, this is reported as the percentage of residents who are performing better than expected at discharge. So it's always going to be a positive number. In the example that we read through earlier, if none of the residents had exceeded their expected level, the number would be 0%. If only one of the 4 did, it would be 25%, and so on. Thank you for joining us today. If you have any questions later, you can always reach out to us at TMC Business Development at therapymgmt.com, and we'll be happy to help you in any way we can.